Bueno, pues ahora vamos a comenzar un módulo muy bonito, cáncer de páncreas, donde normalmente el pronóstico de los pacientes suele ser muy adverso, pero este módulo vamos a empezar por algo sencillo y no sencillo, que es la neoadjuvancia en pacientes no borderline, no irresecables, y bueno, es un debate entre qué se debe de hacer primero, si Coca-Cola o Pepsi, o viceversa. Y después, bueno, ya vendrá el módulo sobre las nuevas terapias basados en los perfiles moleculares, lo cual es algo bastante interesante. Y para dar pie a este debate, empezamos con la doctora O'Reilly, conocida por todos por su excelente trabajo en cáncer de páncreas a nivel internacional. Y bueno, ella nos dará el punto de vista desde oncología médica, porque hay casos en los que se debe de empezar con esta opción y no necesariamente con la cirugía. Así que démosle un fuerte aplauso a la doctora y le dejo el micrófono.
So good morning, buenos dias. Thank you so much for the invitation. It's a real pleasure to be here in Mexico City. So the topic is, actually it's the other talk, if you don't mind. It's the debate. Please, if you wouldn't mind changing it. Sorry about that. Yeah, I saw the right one up before the break, but I guess got changed. Perfect. Okay, thank you. Here we go. So the topic is neoadjuvant therapy for all, and I'm debating the side of neoadjuvant therapy. Dr. Allen will be talking to us about adjuvant therapy. So maybe get the pointer working. Okay, sorry, is the battery gone? Center button. Oh, okay, got it. All right, so these are my disclosures. Thank you. And then, this is, this seems to be, no, I don't think so.
Let me see. No, it's this side.
This one?
So, yeah.
Okay.
Yeah.
Okay, bottom forward. Okay, here we go. So starting with the spectrum of localized pancreas cancer, now that we've got the technology sorted out here, we're going to be focusing on resectable disease and where neoadjuvant therapy fits. But just a reminder for us all that this is a continuum, and we put sometimes some strict definitions around these that perhaps in practice aren't really optimal. And really, a lot of the data comes from the borderline space as well as the resectable space in pancreas cancer. So just a reminder on the patterns of failure in this disease. We know that there's obviously significant rates of systemic recurrence in pancreas cancer, but there's also a subset of people that have isolated local recurrence, and we know that for patients who are diagnosed with stage 3 disease, up to a third will succumb to complications of local regional disease without distant failure. And that speaks to the modalities to consider when we're thinking about neoadjuvant therapy, systemic therapy, and also where does radiation fit. So there's arguments for and against. For surgery, I think this has always been well articulated. It's the traditional paradigm. We have the option of knowing exactly what the tumor looks like in terms of guiding adjuvant therapy. But nonetheless, we know that there's frequent systemic relapse. We know that surgery incurs morbidity, and we know we probably get less therapy into patients using the adjuvant paradigm. And I think if there's an argument for neoadjuvant, probably the biggest one is getting more therapy into more people, not that it's actually a better approach if you compare exactly like per like. So looking at neoadjuvant therapy and just articulating the challenges with surgery first. So morbidity of surgery, risk of complications, and sometimes risk of significant morbidity. And we know that for patients who go directly to surgery, about 25%, depending on what literature you look at, will not be well enough to be able to receive adjuvant therapy in a timely way. And adjuvant therapy is harder in general for patients after surgery. So these are kind of important points to consider in terms of the argument for neoadjuvant therapy. And looking at this with some data, these are data from Hopkins, 1,000 patients. Obviously, this is not randomized. This is a retrospective look, but I think it's pretty compelling to that point. So if you undergo surgery and you have no complications and you get adjuvant therapy, from this data set, your median survival was a little under 2 years. In contrast, if you undergo surgery and have complications and do not receive adjuvant therapy, your median overall survival was half that, right? So this is pretty telling here, right there, just looking at the morbidity issue. So looking at a little bit more detail about neoadjuvant therapy, what are the advantages? I think one of them is potentially a shorter duration of therapy. Secondly is the ability not just to give the treatment, but to be able to give it consistently. The ability to downstage the tumor and to look at both biology and time as selection factors. And you're essentially identifying the person who's most responsive to your treatment as being the person who's most likely to benefit from surgery. So selection here is a critical tool, and that's what oncology is all about, is trying to select the best therapy approach for a given individual. So if we look at adjuvant therapy and we look at the ability to deliver treatment, and these are from the 2 recent studies that define our current standards in the adjuvant setting, the SBAC4 study. So for both gemcitabine and gemcitabine capecitabine, the percentage of patients who were able to receive all plant therapy was under 2/3 and just over half, right? And if you look at the Prognostic study, the adjuvant study, that's the best reference that we have for outcomes in this disease. And if you look at the winning arm, modified Fofernox, again, 2/3 of patients were able to receive all plant therapy. So you can look at it just, again, if you can give more treatment to more people, the same therapy, that may inch up the survival. It's also the counterpoint, which I think Dr. Allen will make, but yes, okay, we only got 2/3 of patients receiving all therapy, but yet we saw this outcome. But again, these are highly, highly selected patients. So looking at some of the data related to neoadjuvant therapy, this is from Dr. Durr and colleagues, and I was involved in this, looking at a large data set of over 5,000 patients, relatively recent, who received neoadjuvant treatment, and looking at the ability to deliver the therapy, about 90% were able to get treatment in. And for those who underwent neoadjuvant therapy who had resectable disease, median survival about 30 months, and for the borderline resectable population, very close. And this speaks to the point that we know that it's very hard to predict upfront for those outside of the extremes who's ultimately going to be resectable. So this is an argument, I think, in favor of neoadjuvant therapy. So I'm just going to highlight a little bit of Dr. Allen's work. This was a very prestigious and important article with regard to complication rates after surgery. There's a 15% grade 3 leak rate, and that's with very experienced surgeons in a very experienced center. And if we contrast that to our Italian colleagues looking at their neoadjuvant approach, the grade 3 leak rate was about half in this population, so suggesting that complications may be less for selected patients. Perhaps was outweighed a little bit by delayed gastric emptying, which did appear to be higher in the group that received neoadjuvant therapy. So looking at neoadjuvant Fofernox in borderline resectable disease, this is a detailed review done from the very productive Dutch pancreas cancer group, looking at 24 studies, 8 of which were prospective, who received Fofernox. And you can see here that the resection rate was a little over 66%. The or0 resection rate was about 80%. And median PFS and OS were interesting in this borderline resectable population. So again, just being able to deliver the therapy is an extremely important factor. And looking at the prognostic considerations, so what do we learn when we give preoperative therapy in terms of predicting who may do well? So this is data from, not a huge subset of patients, but suggesting that if you have a major pathologic response, that's an MPR, that your outcome in terms of DFS, in terms of PFS and overall survival is better, and some suggestion that for patients who received chemoradiation over systemic therapy alone in this setting, that the outcome may be further improved. I think that hypothesis remains to be proven here, that chemoradiation is better in this setting, but certainly the pathologic response rates may be, and potentially a surrogate for better outcome. So what randomized data do we have? We have relatively little randomized data to speak to neoadjuvant therapy, but this is one. It doesn't completely answer the question. This is the PREOPANC-1 trial that was presented at ASCO in 2018. It's in press and will be out very soon. Brief reminder of the design. So control arm was surgery first and adjuvant gemcitabine. The experimental arm, and we can quibble on the details here, but using single agent gemcitabine and radiation, followed by surgery, and then the same adjuvant therapy. So looking at those who received preoperative therapy, as you might expect, the R0 resection rate was significantly better. Toxicity was not majorly different. The resection rate was lower. That makes sense, right? For people who go directly to surgery, you would expect the resection rate to be higher, but even there, it was only 70%. And these are the survival outcome. These data are not mature, and this is an analysis on an intent-to-treat basis. And just rather than getting stuck on the gemcitabine part of it, I think it supports the paradigm that neoadjuvant therapy first may have an advantage here. And this did not meet statistical significance in this initial analysis, and we'll see how the final outcome looks, but the trend suggests in favor of neoadjuvant therapy. And similarly, when you look at disease-free survival, and it's striking how smaller those numbers are compared to the very selected adjuvant data that you're going to see. And I'll just remind you, for the adjuvant patients, you have to be able to undergo surgery, you have to recover from surgery, you have to be able to get treatment, all within a timely way. So again, highly selected patients. This is more a real-world assessment of outcome, but trend in favor of neoadjuvant therapy. And the other data set comes from our colleagues in Asia who looked at gemcitabine and S1 being a fluoropyrimidine that we don't have in North or South America. I don't think it's available here, but is standard of care in several parts of Asia. And here the study design was looking at neoadjuvant gemcitabine and S1, and standard S1 after surgery based on a previous trial by the same group which established S1 as a standard in the adjuvant setting. And these data support neoadjuvant therapy. So this is probably the first high-level positive randomized trial. This was a phase 2, phase 3. And for those who received neoadjuvant therapy, and it wasn't a lot of neoadjuvant therapy, it was 2 months, you'll see the overall survival was about 3 years for that group, and a little over 2 years for those who went to surgery first. And that was also supported, of course, by the 2-year overall survival. So data in favor of neoadjuvant therapy. So looking a little bit more about this and just looking at the adjuvant part as to why outcomes have improved, and it's pretty clear that they have improved, but I think part of it is treatment, no question, but the biggest part is better patient selection. That's what it's all about. And we'll see in the adjuvant trials, the patients are selected based on performance status. They're also selected based on CA99. So typically CA99 less than 2 to 2.5 times the upper limit of normal, depending on what trial you look at. So that weeds out a lot of patients. And I think also our ability to safely deliver these treatments has improved over time, and that totality of factors contributes to improvement in the adjuvant setting. So speaking to a couple of trials that are pending, this is one that will open in North America this summer and Canada, US and Canada, and this will perhaps in either direction define which may be the standard. And a couple of things, it uses the current best treatment that we know, which is modified Fofernox in the adjuvant setting, that's the control, and the experimental arm is giving neoadjuvant Fofernox followed by surgery and then completion of a full course of Fofernox. So this will accrue just under 350 patients, powered for a survival difference, and there are many sort of subset questions built into this. And the PRIOPANC-2, this is the follow-on for the Dutch Pancreas Cancer Study Group. This is their study, which is about halfway accrued at this point, a pan-Netherlands study. And they've taken the approach of building on the PRIOPANC-1 design and moving all the treatment to the neoadjuvant setting. So it's not comparing neoadjuvant to adjuvant, but looking at neoadjuvant Fofernox versus gemcitabine and gemcitabine-based radiation, what was defined from the PRIOPANC-1. So we'll see how that reads out. It's probably going to be at least 3 or 4 years from now, given that there's probably another 9 to 12 months of recruitment. So one other study that's going to inform this space is from the Alliance. This is in the borderline resectable setting. And this looked at neoadjuvant modified Fofernox with or without SPRT. This is a randomized phase 2. And a couple of things. This study closed almost a year ago now, and the SPRT arm closed early. It did not meet an interim analysis evaluation for R0 or 1 resection rate. That was a little surprising to many, maybe not some people in the first row here, Dr. Crane, but who's not been a proponent of SPRT in this setting. But we will see, and this may change our use of radiation in the neoadjuvant setting, or may change the modality in terms of the type of radiation that's used. So more to come on this. This will probably read out in 2021. And just to summarize what's happening in this space, these are some of the studies that are pending. So over the next year to 18 months, we're going to see a readout on a number of European studies comparing older regimens, some using gemcitabine and nab-paclitaxel, which hasn't stood the test of a phase 3 in the adjuvant setting at least, but they of course will inform practice. So I'm going to say 2 words on adjuvant therapy, not to steal Dr. Allen's thunder here, but just again, I want to emphasize the selection process that goes into a patient receiving adjuvant therapy. CA99 and ECOG, getting through the surgery, getting through postoperative recovery, and been able to receive very intensive treatment. Nonetheless, it's hard to argue with success here, and this is clearly success in relative terms for pancreas cancer and absolutely defines the reference standard to beat at the current time. So summing up, I would say there's no one-size-fits-all, and to me it's all about the selection. And I think the biggest arguments for neoadjuvant therapy are not that it's a better approach, but that you do get more treatment into more patients and potentially more modalities into more patients, and that probably will be the win at the end of the day. But there certainly are going to be patients where we will say that upfront surgery, it's an easy resection, it's a fit individual, and you know they'll be on adjuvant therapy in 4 weeks. There's not an argument in that regard. So I'm going to say that at this point, I think the field is wading in the direction of neoadjuvant. So thank you very much. I'll stop there.